From Diamond Pharmacy Services, this is PodcastRx, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. On this episode, frequent contributor Chris Bender from the Diamond Drug Information Center is back, again, this time to talk about treating asthma in the correctional setting. According to a 2015 report from the U.S. Department of Justice, the prevalence of asthma among the correctional patient population was 15 to 20%, compared to just 10% among the general population. It should be no surprise then that Chris and his Drug Info Center colleagues field many asthma questions from providers. Because of this, and because major asthma treatment guidelines have been updated in the past few years, Chris felt asthma would be a timely presentation topic for this year's Spring NCCHC Conference, and ultimately this podcast. Chris treats us to a broad overview of asthma symptoms and therapies before taking us deeper into the treatment issues found in jails and prisons. Along the way, we also talk about the relationship between asthma and COPD and what effect COVID-19 has had on asthma management. I'm Adam Campbell. Welcome to PodcastRx. Chris Bender, you're probably tired of hearing this, but thank you once again for joining us on PodcastRx.
Yeah, Adam, it feels like we just finished recording the last one, but no, I'm never tired of joining you on the pod. So it's always good to be back. Thanks for having me today.
Absolutely, and thank you so much. Before we start, I'd like to acknowledge that this episode is an adaptation of a presentation that you just recorded for NCCHC, and that's the National Commission on Correctional Healthcare, for those who aren't up on their acronyms, for NCCHC's virtual Spring Conference. As we record this podcast, we're just about a week out from the presentation. So you've presented in person at previous NCCHC conferences. How does this experience compare?
Yeah, so Adam, first, I just wanted to say thanks for doing this right now, because I think it's kind of cool to have, sort of like an accompanying piece to go along with the actual presentation that'll be airing at the NCCHC conference. And obviously, we're not going to dig into quite the same level of detail as that presentation would, but I think it's a good thing to kind of get people interested. And if they have any other interest in it, they can always sort of look to that presentation. But to your question, with most other things over the past year, obviously it's a very different experience this time around. It obviously has its pros and its cons because, of course, a virtual conference just isn't going to have as much of the social aspect of an in-person conference does. So of course I'm gonna miss that aspect. But it's important to note that this year's conference, it's not only virtual, but it's also completely free to attend. So, from where I sit, I think there's certainly a possibility for this conference to be one of NCCHC's biggest yet. So, from my perspective, I think this means that my presentation has the opportunity to reach an even larger audience, which is kind of exciting for me.
Yeah, certainly hope it does.
Yeah, that's always the hope. So, but obviously another difference is going to be just how the presentation is actually, given. So in person, it would be me speaking to the crowd. I would be followed up with like a Q&A session. But in this current format, I believe, at least since I already recorded the presentation, I'm actually going to have the opportunity to answer questions in real time as the presentation airs. So I think that's kind of cool because I think it's going to lead to more of like an interactive experience for not only myself, but of course the attendees. And throughout that process, I found another big difference in the fact that I had to learn how to set up my own lighting and my own backdrop in order to look good on camera. So that was fun.
Well, that's definitely not a problem that we have here on PodcastRx. Total face for radio right here, speaking just for myself. But anyway, I digress. Well, one great thing about you and your colleagues in the Drug Info Center is your, I would say, prolific creation of webinars like these that become presentations. And that's especially true for our clients. But of course, for this show, these webinar topics have turned into podcasts. Our episodes on drug diversion, polypharmacy, diabetes, CBD, medical marijuana, just to name a few, that they're great examples of that. So I wanted to ask, how did this particular topic, asthma management, get on your radar for the NCCHC presentation and by extension get here?
Yeah, so it was really driven by a couple different factors. So the first I would say is that, on its face, asthma management seems like it's pretty straightforward. So you add an inhaled steroid, then you add a bronchodilator, you just kind of follow the stepwise process. But, the parts where it gets complicated is when you start to navigate the various brand names of the medications and also the different formulations of many different combination product inhalers. And, we're going to touch on this a little bit, moving forward in the podcast. So where, me and my colleagues sit in the Drug Information Center, we are always fielding different questions from providers and nurses in the facilities. And these are often regarding the different types of inhalers, what's in one inhaler versus another. Even questions such as like a person coming into a new patient coming into the facility, they're on a particular inhaler. Could they be switched to, say, a more cost-effective inhaler that would be the preferred agent at that facility? So we deal a lot with those questions on a day-to-day basis. Another reason that prompted this was because I would say over the past 2 to 3 years, there's really been a lot of major treatment recommendation changes that have come out in recent guideline updates. In fact, probably the most widely used guideline in the United States, the National Asthma Education and Prevention Program, or as I'll refer to it as NAEPP. I know they just updated their recommendations in 2020, and these recommendations were pretty substantial. So they kind of changed the treatment steps that we in the U.S. have been used to following since 2007. And a lot of the treatment paradigms have the potential to sort of shift moving forward. So, with those reasons in mind, I thought it would be a good opportunity for me to provide some education regarding the updates in current asthma treatment, as well as give some sort of refresher, at least, on the various types of agents that are available to treat asthma.
Well, it sounds like a very timely choice.
Yeah, I was pretty happy to be doing that here. So it definitely lined up very well.
Yeah. Well, I think to get going here, we should do a little light discussion of what asthma is. Pathophysiology, diagnosis, treatments. One thing as a host of this show that I really enjoy is having my preconceived notions about a given topic be wiped clean by experts like yourself. So in this case, my understanding of asthma is very basic. You fail to catch your breath, you're wheezing, and then you just clear it all up with the blast of an inhaler. Real simple, right? But of course, there's way more to it. So Chris, can you give me and the listeners a proper take on asthma?
Sure. So I think this is a broad topic. So I will try to do my best to, kind of distill it down into the broad brushstrokes of asthma management and whatnot, just to keep it applicable.
You're very good at that. Yeah.
well, thank you. So let's just start from the top, right? So the understanding, our basic understanding of how asthma works, it's really become more complex in recent years. But for our discussion, we can really keep it more broad by simply starting with the fact that, our bodies have this built-in defense mechanism. And this defense mechanism can be activated, in response to outside triggers, typically like pathogens. So bacterial pathogens, viral pathogens. So of course, this is normally pretty protective because the body ramps up an inflammatory response to this pathogen, which ultimately helps to eliminate the potentially disease-causing pathogen. Now, the problem with patients with asthma, however, is that this process can actually be triggered by non-pathogenic triggers, and these can be, pollen, pet dander, even things like cigarette smoke and stuff like that. So the patient with asthma tends to experience more chronic inflammation in the airways, usually triggered by these, non-pathogenic triggers, which the problem is, over time, this chronic inflammation can lead to structural damage in the airways, and that is why patients with asthma tend to experience symptoms of wheezing, shortness of breath, and particularly whenever they are around triggers that they know can ramp up their natural inflammatory response. So one of the key words that I want our listeners to associate with asthma, because it'll really help to understand how we differentiate it from other things, is variability. Meaning the symptoms of asthma are not always persistent over time. So if you would ask anyone who has asthma or anyone who knows someone who has asthma, they can tell you, that there are periods of time where they are fairly normal, followed by periods of symptom flares or by asthma attacks. And like I said, this is one of the features that really sets asthma apart from other common respiratory disorders, a good example of which would be COPD. So in order to properly diagnose asthma, we look for a patient to demonstrate that key word, variability in their airways. So this is most commonly, there are obviously a lot of tests that can be done to demonstrate variability, but probably the most common test would be having the patient breathe out as much as they can in 1 second. The patient is then given a bronchodilator medication, which is going to help to release the airways, expand the airways. And then they're asked once again to breathe out as much as they can in 1 second. And essentially, we get a patient's before and after measurement, and then we compare the two. So essentially, patients with asthma tend to have a larger difference before and after than normal non-asthmatic patients, because they would respond more strongly to a bronchodilator. So that's basically the nuts and bolts of how it would be diagnosed. But in terms of treatment, you said blast of an inhaler, and you weren't that far off when you referred to it in that way, because obviously most people I'm sure know is that inhaled therapies are the mainstay of asthma treatment. But what I would have our listeners understand is that it's not always as simple as just starting or giving any old inhaler, because there are essentially 3 different classes of inhalers. We can boil it down to that. And they all have their own time and their own place in therapy, okay? So of these 3 classes of inhalers, the cornerstone would be the inhaled corticosteroids. These are recommended to be used in basically any patient with any degree of persistent asthma. And this is because asthma, like we said before, is an inflammation-driven disease, and corticosteroids are just very good at reducing inflammation. So by having a patient use inhaled corticosteroids on a regular basis, we can really help patients minimize disease progression, as well as minimize the frequency of asthma exacerbations or asthma attacks. So that's one of the 3 classes. The other 2 classes of inhalers are called beta agonists and muscarinic antagonists. And essentially, both of these classes, they just cause bronchodilation, meaning they open the airways. And this ultimately improves patients' breathing. But to somewhat complicate things is that both the beta agonists and the muscarinic antagonists are available in short-acting and long-acting formulations. So just for some nomenclature here, short-acting beta agonists are referred to as SABAs, while long-acting beta agonists are referred to as LABAs. And of course, this same logic applies to the muscarinic antagonists, where we have SAMAs and LAMAs. So you might be wondering at this point, why is this short-acting and long-acting distinction relevant? And that's fair. So that's because patients with asthma, regardless of their severity, they should always have a short-acting agent available for basically for whenever they experience symptoms. So this is usually what's portrayed on TV and in movies. Anytime you see a patient pull out their inhaler, shake it, and take a puff when they're feeling wheezy, that's a short-acting inhaler there. So typically speaking, a patient who has persistent asthma is going to be taking an inhaled corticosteroid for their maintenance on a routine basis. And then they're also going to have a short-acting bronchodilator to use on an as-needed basis. Now, that's the short-acting stuff. But the long-acting bronchodilators, so the LABAs and the LAMAs, these are often used in patients essentially in whom these previously mentioned treatments aren't enough. So they're a greater degree of severity. So they're already on a steroid as well as an as-needed bronchodilator, but they need more maintenance medication. So these are the patients who are going to be using an inhaled steroid along with a long-acting bronchodilator, both of them for maintenance. And then, of course, they're still going to have their short-acting bronchodilator to use, on an as-needed basis. And I should even note that, there are even patients who require all three major classes together, meaning they're going to be using an inhaled steroid, a LABA, and a LAMA together. But fortunately, there are now inhalers on the market that contain all three of these agents together, and that has the potential to really dramatically improve the ease of therapy for these patients. So to just kind of run it back a little bit, I know we went over a lot of broad brushstrokes there. I just want to say that in general, it's important to summarize that some patients, those who don't have persistent asthma, they can get away with just using a short-acting bronchodilator as needed with nothing else. But for those patients with persistent asthma, the general treatment progression is going to be from an inhaled steroid to an inhaled steroid plus a LABA to an inhaled steroid plus a LAMA, or plus a LABA plus a LAMA, meaning you go from one agent to two agent to three agent.
Well, that's a really great breakdown, Chris. Really appreciate that. Sorry. I really appreciate that. Yeah, I can imagine that was really tough to distill that down into those chunks, but you did it.
I appreciate it. That is essentially 30 minutes of the presentation at NCCHC boiled down into a couple minutes of a podcast there.
Yeah, it was great. Now, I do have a real quick follow-up about variability. Something I wondered, and I had seen this in someone I've known in my family, but can asthma be present in someone at a younger age and then just effectively go away as they get older?
To be honest, I'm not sure of them growing out of it. I don't see why they couldn't.
Okay.
There is some degree of genetic, there is some degree of environment.
Mm-hmm.
You could be more hyper, have like a more hyper-inflamed state as a child, but then, because it kind of overlaps with allergies too. And
mm-hmm.
we know that patients I shouldn't say patients, but like people in general, they can grow out of allergies as they get older.
Right.
So I would say allergies have, or asthma has an allergy component to it. So maybe just like the allergy component, they could grow out of it as well. Because you could also have adult onset asthma too. Mm-hmm. So I would say it is less common to kind of grow out of it, but it certainly wouldn't be out of the realm of possibility.
We need to take a quick break from this conversation. While you're waiting, this is the perfect time to follow Diamond on social media. You can find us on Twitter, LinkedIn, and YouTube. And if you're local to our Indiana, Pennsylvania headquarters, you might like to follow our Facebook and Instagram pages for our Diamond Drugs and Medical Supply stores. We welcome your likes, shares, retweets, and comments on all platforms. And now, back to the show.
We're back here on PodcastRx talking to Chris Bender about asthma management. Now, Chris, one of the first things you mentioned in your presentation's preview material is that asthma is more prevalent in the correctional population than in the general population. I was surprised to learn this. What are the factors behind this?
Yeah, you and I both, because when I first read this, I was surprised as well. But according to, I think it was a 2015 report, it came from the U.S. Department of Justice, where it said that the prevalence of asthma among those correctional patients was anywhere from 15 to 20%, and that was compared to roughly 10% in the general population. So this is possibly due to the fact that, like I said before, the development of asthma is influenced not only by genetics, but also by environment. And obviously, while I don't think genetics would play a role in explaining this particular scenario, I do think that environmental factors could. So I know that typically we tend to think of asthma as a disease that occurs in childhood, but there is a population of patients with adult onset asthma. And this adult onset asthma has a lot, it tends to be more common in those patients who smoke. So while there hasn't been any great explanation to this increased prevalence, I do think that maybe smoking could be playing a role, maybe increasing the rates of adult onset asthma, especially considering the fact that there is a higher rate of smoking among incarcerated people compared to the general population.
What exactly makes asthma tougher to treat in the correctional environment? And how can corrections health personnel identify and overcome these difficulties?
Sure. So first and foremost, asthma treatment is complicated by the sheer number and variations of inhalers available. So I know that we previously discussed, the broad brushstrokes of treatment, which for simplicity, we distilled it down into 3 different classes. But, it's important to note that there are actually 26 inhalers that are FDA approved for asthma in the United States. And that's in addition to 12 other inhalers that are approved for COPD. So there's just this absolutely massive amount of inhalers out there that can be a common source of confusion, for anyone who would be dealing with this. Another thing that complicates that is, in addition to all of these different brand names and different inhaler types, is that of those 38 inhalers, there are many of those inhalers that are combination products. And for asthma, we commonly see the combination of inhaled corticosteroids and long-acting beta agonists. Those are like one of the biggest combo products used in asthma. So because of this, it would be easy to see how prescribing mistakes could be made. This could result in patients taking duplicate therapies. So I know, for example, we commonly see patients who were on like an inhaled corticosteroid, but then they had an inhaled corticosteroid LABA combination added to their profile, where the provider wasn't maybe aware that there was already a steroid in that product, so that you would then get duplicate steroid therapy. So this is something that we kind of intervene on from time to time. Another complication that's often not thought of, that is kind of unique to the correctional environment, is that some inhaler devices can actually contain metal, springs, and even needles, which means that certain inhalers are just not allowed to be kept in a patient's cell. So, this creates a complication because when a patient has to go to the med room daily, multiple times a day, depending on the dosing of the medication, just to take their maintenance inhaler, we obviously start to worry about how that might affect the patient's adherence to that therapy. So the less adherent you are to your maintenance therapy, the more prone you are to asthma exacerbations. So that can cause, some issues. So that's why, of course, an ideal product would be one that a patient could keep on their person at all times. And there are many cases in which we can do that and select those products. But obviously, product selection plays a big role. But in terms of, what healthcare personnel can do, I know this sounds like a shameless plug, but I would suggest contacting your pharmacy and your pharmacist. And this is because I can't I can't tell you how many positive discussions that I've had with both nurses and providers. Simply just being able to assist them in navigating through either asthma or COPD treatment, selecting an alternative product or streamlining certain products, going from a patient who's taking 3 separate inhalers, combining them into 1 inhaler, just a lot of things like that the pharmacist can help streamline. And obviously, I'd also recommend that providers simply familiarize themselves with the current treatment guidelines and treatment options. Because like I said, NAEPP just released the new guideline update in late 2020. That is available publicly. But another thing that I really love is the it's the Allergy and Asthma Network. They actually have a pretty awesome inhaler chart that's available for free electronically on their website, or you could buy a poster of it for a small fee. But I think it's a great resource because it not only shows you what the product looks like, it also tells you like what class it falls in, what agents are in the particular, like physically what drugs are in the inhaler and what strength and stuff. So for a med room, I think it's an invaluable resource. So I'm assuming we can put those links in the show notes for providers.
We absolutely will mention those resources in the show notes. A quick follow up here, Chris. Mm-hmm. We've talked with you about drug diversion on a past episode, and in that discussion, you and your previous colleague Erica, you talked not just diversion of drugs but also ancillary objects. So you mentioned about inhalers having metal springs or needles. Are there any other concerns for misuse with an inhaler rather on a drug level that corrections health providers have to deal with?
I think that's a great question, because typically speaking, the maintenance inhalers are usually fine. There's not been a lot of diversion issues with those. It's usually the short-acting product, and typically, I'm talking specifically about albuterol or levoalbuterol. So people may be familiar with that. Albuterol as like Ventolin, ProAir. Because of the way it works, it's more of like a stimulant-like property. It opens up the airways. It can increase the heart rate. So there have been reports of people in corrections over using the albuterol to kind of get a rush. I know there's reports of people using it, especially before working out, to try to get like a better, for lack of a better word, like a better pump on at the gym. Mm-hmm. So albuterol does tend to pop up on, those lists of possible diverted medications in the jail setting. But what I would say about that is that, like on that previous episode that we talked about drugs that at risk for diversion, there's obviously like a lot of good alternatives to a lot of those ones. Unfortunately, like the answer to those ones would just be like, don't use that particular drug, or keep that drug away from those patients. But the problem with albuterol is everyone with asthma should have an albuterol inhaler on board. So there's no real way around this one, especially because they tend to be kept on person, because what happens in the event of an acute asthma attack, you wouldn't want them to have to be at the whim of the med room. So this is one of those cases where, yes, it is a potentially diverted medication, but it is, for lack of a better term, a necessary evil in this particular case.
Understood. Moving on, Chris, COPD, we talked a little bit about it in the discussion of asthma. Can you explain a little more how COPD complicates, relates to asthma treatment, and how often do the conditions between asthma and COPD overlap? And lastly, how prevalent is COPD in the correctional population versus the general population?
Sure. So to understand COPD, it's important to understand that higher rates of smoking would increase the rates of COPD. So by the same logic that we mentioned before, with smoking and asthma in the correctional population, it should be no surprise that COPD prevalence is usually fairly higher in the correctional population compared to the general population. In fact, it's about 20%. It's seen in about 20% of folks in the correctional population. With regard to asthma COPD overlap, like them occurring at the same time, it's not uncommon to see this. I would say I've seen estimates really vary with this one, but I've seen around 15%, meaning 15% of people with asthma will have COPD and vice versa. So I would say this is probably a pretty considerable amount. Now, I should say that the three broad classes of medications that we discussed previously are all used, at least to some extent, in the treatment of COPD. So that's helpful. But, to put it simply, the treatment of COPD is kind of reversed from that of asthma. So let me explain. In asthma, like I said, we would start with a steroid and then progress to the bronchodilators, whereas in COPD, we start with the bronchodilators, and only in some select patients we would add on the steroids. I will say that inhaled corticosteroids do not have nearly as much of a role in COPD as they do in asthma. But if you were to use them in COPD, the inhaled steroids, that is, you would reserve them until after you've already put them on bronchodilators. So because of this, it would really make sense that in patients who have both asthma and COPD, that we would want to make sure that they're being treated with both a steroid and a bronchodilator. So this is usually a pretty convenient way of kind of covering both of your bases. Where I would say COPD complicates things, to use a pretty common example, would be when a facility admits a younger-ish patient, so let's say like they're maybe late 30s, the patient claims that they have only a history of asthma. So the provider, of course, would start them on an inhaled steroid, thinking that's the proper treatment for a patient with only asthma. However, over time, a couple of months go by, they keep increasing the dose of the steroid, and they realize this patient isn't responding to the inhaled steroid. What they may not realize is, excuse me, the patient may also have some COPD overlap. And like I said before, the first treatment for COPD would be bronchodilators. So these patients would actually benefit more from having, rather than, the steroid dose being upped and upped and upped and upped, they'd be better off having a bronchodilator added to their steroid. And I've actually helped providers kind of manage this in different, in previous patient examples. And often a simple addition like this, it kind of changes the patient's entire outlook.
Well, Chris, we're talking about respiratory conditions, so I have to ask about COVID-19. Has that affected the complications with asthma management that we've discussed so far?
Yeah, and I think it's certainly omnipresent in this day and age to discuss a little bit of COVID. So I would just like to say that obviously up front, I'd like to remind our listeners that patients with respiratory disorders are highly recommended to receive the COVID-19 vaccine. And this is much as the same as they would against influenza and pneumococcal disease. So I just kind of throw COVID-19 vaccine recommendation in right alongside those two. But with that said, I was kind of surprised to see a report from the WHO that actually just came out. It was on the 19th that came out, and it kind of muddied the waters for me with regard to any association between COVID-19 and asthma. Because typically, we tend to think asthma patients are at higher risk of contracting COVID, higher risk of developing severe COVID, as well as complications. But from this most recent report, at least with regard to the risk of acquiring COVID-19, they weren't able to draw any firm conclusions. Likewise, with regard to COVID-19 severity and mortality, they also didn't see any associations between asthma causing any worse outcomes. Now, I think the important thing to note here is that the WHO did acknowledge that these conclusions are just based on scarce and imprecise data. Like I said, this lack of a relationship is kind of opposite of what we tend to see in patients with influenza and pneumococcal disease, right? So we tend to see higher rates of those diseases in asthmatics. We tend to see more severe disease in asthmatics. So I think that while this is certainly interesting right now, I think that over time with better data, we're going to have a more clear picture regarding that association between COVID and asthma. So for now, I think it's just safe to say that we should continue to take precaution, if you or someone has asthma.
I'm sorry, Chris. I'll say we'll also link to that report in the show notes as well from the WHO.
Yeah, absolutely, because I think it was an interesting read. And I also think you see a lot of headlines that are saying, well, maybe now you don't have to worry so much if you're an asthmatic. But I think the devil's in the details. And that's why I wanted to say that, the WHO does acknowledge that we still don't have the best data out there. So I think it's important to look at it for yourself.
Yeah.
One thing, and I just kind of wanted to end my thought on this, is fortunately, these patients are taking inhaled corticosteroids. Corticosteroids do have the potential to lower the immune system, at least when you take them at high doses systemically, meaning whether you're giving them intravenously, chronically, or chronically orally. The use of inhaled corticosteroids or other inhaled therapies for asthma have not been associated with any increased risk of infection or poorer outcomes. So I thought that was important to note. In fact, some inhaled corticosteroids have and are currently being studied for the treatment of moderate COVID-19. Now, these studies have provided some mixed results. I mean, some of them show that there may possibly be an effect, while others show that there isn't an effect. So all of this is to say that patients should feel comfortable continuing their current therapies as they have been. And because, of course, the risk of exacerbation can really be serious in its own right, too, if you were to stop taking those medications abruptly.
Right. Definitely not a time to let your guard down. Well, Chris, we've hit our time limit. So I wanted to wish you good luck with this presentation at NCCHC next week, the asthma presentation. I believe it's called Breathe Easy is the title of your talk. Yeah. And perhaps some of the folks who just listen to the podcast, maybe you got to listen to Chris's presentation at the conference. This show is obviously going to come out after the conference presentation, but regardless, you do a fantastic job of breaking down a topic like this. We really appreciate it, and thank you once again for being our go-to expert.
Well, Adam, I appreciate you having me. I hope everyone who, if they did attend the conference, found the presentation useful. As with any of my presentations, I make sure to leave contact information if anyone ever has any questions. And hopefully people found this podcast useful. So I know I had fun putting it together. So thanks as always, Adam.
Thank you, Chris. This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.